Okay, go.
I'm just going to read what she has, because we broke it up. She did what it is, and like the signs and symptoms, and then I did the treatment and how you diagnose it.
Okay.
And so we did apraxia of speech, and it's a motor speech disorder that the messages from the brain to the mouth are disrupted, and the person cannot move his or her lips or tongue to the right place to say the right sounds correctly, even though the muscles are not weak. So that's like if they're like thinking about what they want to say, they know what they want to say or respond, and they're not able to verbally do it, which I think could be incredibly frustrating. Individuals with apraxia can demonstrate difficulty imitating and producing speech sounds marked by speech errors such as sound distortion, substitutions, and/or admissions, inconsistent speech errors, groping of the tongue and lips to make sounds and words, slow speech rate, impaired rhythm, better automatic speech. Examples would be greetings, then purposeful speech, inability to produce any sound at all in severe cases, and it's diagnosed by a speech-language pathologist. They have two types. They can either do formal assessments or informal assessments to diagnose it. The assessment usually includes examinations of an individual's oral, motor abilities, melody of speech, and speech sound production. And the treatments available, they focus on intervention and improving the planning, sequencing, and coordination of movements. The muscle of speech often need to be retrained. They kind of need to be retrained how to say the words correctly and the sounds correctly. There's exercises that they can practice to do correct mouth movements, and they will have a slower speech rate. And in severe cases, there's argumentative and alternative communication, and that is used to express thoughts, needs, and wants and ideas, and they use it making facial expressions, gestures, writing it. And I found a really cool video of this app, I guess it was, because it was on an iPad, and it had phrases already programmed in it, and the person just had to push it, and it would say, like, I need to speak with my doctor, or I need to go to the bathroom. So it's pretty cool because they could program things in there that the family thought was important, and then the person would just have to push the button in order to communicate it.
Okay, so with this, they don't have where they're not really understanding.
Sorry, what was that?
They don't really have where they're not understanding what other people are saying to them.
They, from what I understood, was that they understand what people are saying. They have problems communicating. Like, they know what they want to say, but they can't make their mouth move to say what they want to say.
Okay. Oh, awesome. Okay. All right, good. Thank you guys on that one. And then, Becky, if you want to do the last one for the last group.
Okay, can you guys hear me?
Yep.
All right, hold on just 1 second. Okay. They did anomic aphasia, which is associated with lesions of the dominant temporal parietal regions of the brain, although no single location has been identified. The person understands words and speaks readily but struggles to find the words. They are unable to remember crucial content words. There is an inability to name objects, and there is a high frustration level of the patient because they are unable to come forth with the correct noun. Some things they looked up on the internet. There's 3 main types of anomia. Word selection anomia occurs when the patient knows how to use an object and correctly select the target
object from a group of objects and yet cannot find the name of the object. Semantic anomia is a disorder in which the meaning of words becomes lost. In patients with semantic anomia, a naming deficit is accompanied by recognition deficit. And then there is disconnection anomia, which results from the severing of connections between sensory and language cortices. Patients with disconnection anomia may exhibit modality-specific anomia, where the anomia is limited to a specific sensory modality, such as hearing. It is one of the milder forms of aphasia, and this form applies particularly to verbs and nouns. A person with this commonly uses fillers or utters sounds when trying to find a name for the object. The person could also describe the object fully when they do not know the word for it, and this is called circumlocution or something like that.
Okay.
And that's all she sent me.
Okay, no, that's good. Actually, it does sound like the least drastic of all of them that we talked about.
You know, the funny thing is when I was on my chemo medicine, I actually experienced what sounds like something similar to that. I could be looking right at my computer, and I could know it was a computer, and I could tell you everything it does. I could say, you know, that thing you sit in front of, and you get on the internet, and you type on it, but I wouldn't be able to think of the word computer. I had that really, really bad when I was on chemo.
Wow, and you know, that's something that most of us can probably relate to doing that at times, being unable to find the word, but that doesn't necessarily mean we have aphasia. But for something like that, with being on a medication, it's like a secondary effect that it caused you to have that probably quite often.
It did. It was very, very frustrating. So I feel bad for the people that do experience any of that, because it's very frustrating.
Right. Okay. All right. Good job, you guys. We still have another 7 minutes that we can get through our questions that we're going to do. So Yvette, go ahead.
My question would be, when it comes to it was in the PowerPoint about dementia and the implications for nursing, and it goes over the medications, and you stated, like, you know, about the giving them maybe anxiety meds and pain meds, and that will actually help with the dementia and the delirium. I am kind of confused about that one, because everything we've been taught has said no. I mean, I can understand, like, it calms them down a little bit, but then I would think, too, like, medication disorients them a little bit, too. So is that another case of the good outweighing the bad?
Right. And so the problem for you guys is that you have been taught by me, who doesn't believe in giving all these addictive substances to people in general, because it's the nature of my work. However, we have to look objectively from each set of circumstances with people. So they did talk about how anti-anxiety meds and things that normally I'm all against could assist with the patient with dementia. And you're right. It's going to help to relieve some of that anxiety and to calm them down. And it's going to be risk versus benefit again, is where that would come in. So would we use them in all patients? Nope, because sometimes we give Ativan or Xanax to a geriatric patient and it has the opposite effect. Makes them way worse as far as their anxiety and their disorientation. But other times we can give it and we'll actually calm them down and make them feel much better. So it's always going to be a risk versus benefit thing throughout the whole entire population of age groups when it comes to that. But there would never be a set sound. We're never going to give this med to this group of patients. But do we need to use caution? Absolutely. Sarah, I know you had your hand up.
I didn't know if we were going back around in a circle. Oh, I'm actually. Okay. I had a question. I can't remember what chapter it's from now, but I was reading about on our PowerPoints like assessment. It's either 20 or 21. And when I was reading the book, it said to not do them immediately after they wake up. Is that
For a
'cause I
patient,
thought morning was like a better time.
for a patient with dementia or just a geriatric patient?
Yeah, I think it was the dementia chapter. I'm trying to find it. Yeah. Yeah, because it was under considerations in cognitive assessment.
Slide 5, okay.
So it says, in the book it says timing is important and cognitive assessment should not be conducted immediately upon waking from sleep. Does that just mean in general, like, if they are, like, I don't know. I guess does that mean, like, not in the morning? Or, because I thought morning was a good time to do it before.
Well, and I put right in here, assessment is best completed immediately upon awakening. I'm going to need to, what page is that on?
311.
All right. Go ahead, Danielle.
In response to it saying not to do it when they first wake up, just from, I guess, my experience with, my family and stuff, typically there's a lot more confusion when they're first waking up. So to do those kinds of assessments, they're still struggling to kind of orient themselves to kind of where they're at, what's going on, because they're just waking up.
Right.
And so doing those kinds of assessments, the level of confusion often is already, pretty peaked up. So to do those right away could agitate, further confuse, and I don't think you would really, in my opinion, get a good assessment at that time of the day, or at that moment in time, just after they wake up, no matter what time of day it is.
What I'm going to do with that one, Sarah, is I'm going to look at that page when we're done with our session here and look to see why I put that in there because, making these, I went through a lot of these fairly quickly through the book. So let me reassess that whole thing, and then I am putting together this thing that we just did together, and then I'll include that in there because it's going to be like a little sheet that I'm just going to put together from this. So I will answer that. It just won't be at the moment. No problem. Okay. Who wants to go next? We got 2 minutes on this thing, but then we're done with that and we're going to keep going. Go ahead, Danielle.
Since we're kind of on the topic of the dementia stuff, I was actually, when we were doing the discussion board for you, the question was, if you were to create this unit, what would you put in it? Through reading, they say, this is good, this would be a good thing to do. But what are like some of those key things that you should expect to find in every unit that's set for a dementia Alzheimer's style patient?
Well, the first thing would be like the consistency. So, you would want to keep, like, you wouldn't be changing a lot of stuff around, because if you think about an Alzheimer's unit that people do, and I don't know if you have one where you work, Yvette, but that stuff stays consistent all the time. Things like even just the decor on the wall. You want to do things that are a little bit more mild in nature and not stuff that's loud and distracting, things that can cause people to be upset. Yvette put alarms. Alarms are definitely something that you would have for every patient in their rooms, depending on, I guess, the patient really. But yes, especially if you have people who wander, the locks on the doors, because typically they're locked units. Alzheimer's units would be. I'm trying to think, like, do you mean like specifically like caregivers, or like things in the units, like devices to walk with, or like what is your specific question as far as what you're looking for the consistency, like the scheduling of?
Yeah, there were a lot of things that were like,